Emergency departments have a bad reputation for experiencing long wait times to see a physician and long wait times to receive treatment. The national average for emergency department wait times is around 30 minutes, and then another 90 minutes to seek treatment, which is roughly 2 hours spent in the ER. There are many cases in which this can be much longer. In hospitals expecting 50,000 or more annual ED visits, the average wait time is 48.7 minutes. ED overcrowding is when the need for emergency services exceeds the available resources for patient care. ED overcrowding is associated with delays in diagnosis, treatment, and hospital admission, increased length of stay, preventable medical errors, increased patient costs, and decreased patient satisfaction and willingness to return. Of the 100 million patients presenting to US EDs, 15 million of them are uninsured. One example of the impact overcrowding has on patient outcomes is a patient that I had that presented to the ED with a closed tibial fracture, crushed patella, and several torn ligaments. He presented during a high volume time of day and season, and the patient was rushed through triage, and he still waited over 30 minutes to be evaluated by a physician, although he was in excruciating pain and should have been a priority for staff. There are many studies conducted to evaluate various methods of decreasing wait times and overcrowding. One method in particular has shown encouraging results, where time limits are imposed on evaluations, referrals, and length of stay, and the ED and patient flow has been restructured to include 3 pathways of care based on initial triage assessment. At each level, they are assessed for continued medical needs, and their placement is determined either through admission or short stay in the emergency department, or their readiness for discharge is evaluated and they promptly detected. The financial implications for this method would include ensuring enough staff are present to run each stream of patient care. This would include nurses, techs, physicians, residents. The same amount of staff would be needed to run a typical ED with the original structure. Costs associated with restructuring the setup of the ED. There may be some costs associated with reconstructing the layout, but these should pay off in the long run. Although, since this method has shown such a significant improvement in wait time and length of stay, there are reduced costs associated with availability of beds, supplies, and staff. So the cost shouldn't be too big of a factor in implementing this new method of ED triage. Thank you.